Farana, and I work with programs with Department of Education and Skill Building at Palliative India Trust. I will be one of the facilitators for this batch. So moving on to the faculty introduction, Dr. Sanghamitra Bora is the consultant and lead palliative care at Assam Cancer Care Foundation. She has over 15 years of experience in palliative care. Her areas of interest are cancer pain management, end of life care, palliative care health services, research, home health care services, and palliative care education. She has major achievements. She has received the Special Bursary Award from the St. Christopher's Hospice, London in 2013, the Commonwealth Scholarship from for MSc Palliative Medicine from Cardiff University in 2014. She's been the national trainer for the National Health Systems Resource Center for the Government of India since 2021. She's a national faculty of Indian Association of Palliative Care since 2012. She's a faculty and resource person of Trivandrum Institute of Palliative Sciences, Pallium India since 2014. She's a reviewer of the Indian Journal of Palliative Care since 2016 and Oncology Journal of India since 2021. I welcome you, ma'am, for today's session, and I hand over the session to you. Thank you for joining.
Thank you, Dr. Hashmat. And I think I'm meeting Gayatri for the first time. Hello, Gayatri.
Hi,
nice to meet you. Yeah. And of course, Sri Priya. Thank you so much for having me once again for to start this course. Thank you so much. And it's always a pleasure to have an interaction with people from all over the country. I hope I'll be able to do justice to this very important topic today. I'll try to, give you as much as I can. The time is too short, but then still I'll try. So maybe I'll just try to share my screen, and please let me know if my screen is visible to all. Can you see my screen?
Yes, ma'am, it's visible.
Yeah, okay. So I'm going into the presentation mode now. So we are talking about palliative care today, and I'm sure this is not new as of now to anybody, anybody in the sense the professionals of healthcare industry, whether that person is a doctor or a nurse or a caregiver, or somebody who's related to cancer, somebody who's related to serious illnesses, somebody who's related to end of life care. So I'll just go through very basic things that we all should know. And I'm sure, we already know few bit of things, but just to place them in a systematic manner so that, we remember what things to be approached, which are the things not to be included, etc. So basically, the WHO definition says that it is an approach that improves the quality of life of patients. And it's not only the quality of life of patients, it is also the quality of life of their families, the families of patients. And basically, those patients who are facing problems associated with life-threatening illnesses, and that would be definitely through the prevention and relief of suffering by means of early identification and impeccable assessment, and the treatment of pain and other problems like physical problems, psychosocial problems, spiritual problems, emotional problems, etc. So the zest of palliative care, the essence of palliative care lies in improving the quality of life of patients and their families. And when we talk about quality of life, I generally, what I myself do is to compare my life with a person who's actually is not in the same state of physical being. For example, if I'm talking about, if I have to, say about my quality of life, I would say I would want to have a good meal on a daily basis. I am able to get 6 to 8 hours of sleep. I am also able to, get recreation out of activities that I love. Um, I am not dependent on anybody else for my daily activities. So that is quality of life for me. And henceforth, if you have to think about the quality of life for yourself, then you will have your own criteria. So that generally means that this is absolutely individualized or subjective. So palliative care would be a subjective phenomena. The approach would be subjective. And that also infers that we need to approach patients with taking this thing in mind, that his criteria of quality of life would be his own version. So that is the reason why we say that the patient is in the core of the care process. And that is why palliative care for a patient facing a life-threatening illness and the problems associated with the illness, along with the patient's family, would have an approach completely tailor-made for them. So that is what is generally meant by this particular definition of palliative care. So the modern approach to palliative care was developed from the pioneering work of Dame Cicely Saunders, and I'm sure you know about Dame Cicely Saunders. Nevertheless, I would actually want to tell about her because she is the pioneer of palliative care in the world. She's supposedly called the mother of palliative care. She was a nurse in the UK. She came out with a lot of work related to palliative care nursing, palliative care medicine, and and she actually paved the way to establish modern palliative care. So the model of care, which is applicable across a range of life-limiting and life-threatening illnesses, would certainly encompass diseases like cancer, cardiovascular diseases, respiratory diseases, neurological diseases, and any other disease that you can actually think about. I'm also going to show you in the next few slides about a concept called serious health-related suffering. So palliative care is actually increasingly being recognized as an international human right. Nobody in this world should be suffering from any kind of health-related condition. The phrase called suffering should not be related to any kind of health condition. So that is the work that we look forward to. That is the thing that we need to understand and apply our knowledge to reduce that from a condition. So basically, it is essentially an exploration as to what can be done to avoid or reduce suffering in the last phase of your life. If if you actually debate with me why the last phase of life, I would say, the as the uh, baby is born, if he is born healthy, he would actually become an individual at one point of time. He might have some difficulties, because of a disease, but then uh, the innate immunity of that individual fights it back. He jumps to the normal phase of life. But then there would be a point where, that individual actually gradually declines towards the end of life, towards the last days of his life. And that is where, everything actually tries to jump over that individual's health, that individual's mental status, and so many other things actually get multiplied in that particular phase of life. And that is the reason why, palliative care might be quite intensive in the last phase of one's life. And this has also to make sure that people die with dignity. We always talk about life, but then talking about death is a taboo. So that's the reason why, we as healthcare personals or even individuals of the society, we do not generally talk about death. And we never know how people die. We do not come to know. I mean, 15 years back, when I was not in palliative care, and perhaps working as a junior resident in a hospital, ICU, perhaps, maybe ICU, if I take the example of working in the ICU, I might have concentrated more on the issues, the physical issues that a particular diagnosis has had, and what my senior has advised to do. And that might have limited my knowledge of, the proper approach to a patient who might be dying in the ICU. But the dignity factor that comes into play for an individual who is in the ICU all alone, without family members surrounding them, the suffering is manifold. And that you will be able to understand only when you yourself have undergone such a problem, or you've seen somebody of your own, going through that problem. So this is important for all of us as professionals, as doctors, to understand that we must bring in the dignity factor to a dying patient. And that is where there are the intensity of providing palliative care, the innovations that a professional comes up to provide palliative care is really intensified, and it's really, it becomes huge. So I want to share a little bit of the historical process of development of palliative care. So this is a small timeline. As you can see, the concept of hospice actually developed between the 12th and the 20th centuries. And it's considered, it was at that point of time considered a place of rest for travelers. And by the time the St. Christopher's Hospice in the UK developed in 1967, the concept of providing hospice care or the resting place for travelers actually started modifying into, a resting place for people who are going to die, or, a place where such patients or people could be taken care of, during the last phase of their life. And then, in the US also, it started only in the 1974 period, and which is quite late. It's quite late. But then you can see India got its National Cancer Control Program in 1975, and that was a game changer, because hospice care, palliative care was actually a kind of a contemporary word or a phrase for palliative care. Cancer was synonymous to palliative care. We really didn't have too much of cancer-directed therapy at that point of time, but then whatever was there, it was all, most of it was a little less disease modifying and more of providing end-of-life care or palliative care to cancer patients. In 1984, the National Cancer Control Program was modified to include pain relief at the basic service, and which was at the PHC level. And in 1986, India got its first hospice by the name of Shanti Avedna Ashram in Mumbai. Those people who are from Mumbai, definitely you must be knowing about Shanti Avedna. And Shanti Avedna also has a branch in Delhi, and one of these branches are also in Assam. From 75 to 86, these years have been really, really rich in actually promoting hospice and palliative care in India. At the same time, if you compare, from 70, I think from 67 till 87 in the UK, not much of milestones have been seen, except for the fact that in 1987, there was a quarterly hospice bulletin that was released in the UK, which definitely contained a lot of, crux and stories and facts about hospice and palliative care. But then palliative care went on actually developing and increasing its coverage from 75, till 2016. And if I have to, read this, in 1990s, there was this particular NGO formed called by the name of Cancer Relief India. If you know Miss Jilly Byrne, she is supposed to be the first palliative care nurse of India. She's a British national, but then she actually took this brunt of developing palliative care in India through Cancer Relief India. And in 93, the Pain and Palliative Care Society was formed in Kerala. And in 1994, the Indian Association of Palliative Care, which is the umbrella organization of for palliative care in India, was started. 2001, the NNPC, or Neighborhood Network in Palliative Care, had started to take shape in Kerala. In 2003, Pallium India was formed, and going on to the a change in the state policy of Kerala, including the palliative care policy. 2012, Maharashtra state policy was formed, and in 2013, the national program in palliative care was developed. Dr. Rajagopal sir has a lot of contribution to developing palliative care in India. And that was evident right from the time of forming of Pallium India to, bringing about the NDPS Amendment Act in 2014. And then, of course, it went on to the Pune Declaration and so many other changes thereafter, which I have right now not included, because it went on. And right now, India is a super specialized palliative care country, because we do have renal palliative care, we have cardiac palliative care, we also have cancer palliative care. So just to give you a small pinch, maybe just trying to tickle you by showing this particular picture. This is a manual labor, picture of a manual labor. He is around 42 years. As you can see in the picture, he has a cancer of the cheek. He is living with his wife and his two children. Both the children are minors, aged 9 and 5. And he comes to your OPD with pain and a foul-smelling wound, as is, very common with cancer. So the question here is, what do you think is the disease? And do you think that the illness might be a different thing? Or do you think that the illness is inside the disease? Or is the disease a part of the illness? So if you can just tell me in the chat box, you can unmute, or you can just give me 1 or 2 answers. I can give you 50 seconds for that.
Disease is the part of the illness.
Okay. And why do you say so?
Everything coexists.
Okay. All right. And what do you think might be differentiating the disease from the illness? Because you said disease is part of the illness. So what is there extra in the illness? So
illness is the part of the disease.
Okay. All right. Okay.
Because
So let's
disease is the cancer, and the illness is all the sufferings whichever is suffering from because of that disease.
Okay. So I think it's the flip side of both, because if we talk about the disease as a professional, I would normally see the squamous cell carcinoma of the cheek. And then what is evident to me is an infected cancerous wound, because of which there is a foul smell. Now, the illness is a larger spectrum, as Madam has actually truly mentioned, that disease is actually part of the illness. So the illness would be the squamous cell carcinoma of the cheek with the infection, the pain that the patient is bearing. He might be having poor appetite because he is not able to eat, and when he's not able to eat, he's actually losing weight. He's all the more tired. He has a disfigurement. He has an altered body image. I mean, as a doctor, if it was 15 years back, before I was exposed to palliative care, I would have actually seen the disease. and I would have tried to, curb the disease by some kind of a treatment. But then if I don't look at the illness, the holistic view, I would be missing on many parts. I will be taking care of just one part of the illness. And that is where, the approach to a patient changes. And, not only the physical part, the questions like, what will happen to my family after I'm gone? Are we supposed to answer those questions? Or are we equipped even to answer such kind of questions? What should we do? If I think that I am not the person, I'm not the right person to answer this question. If the patient says, what will happen to my family, doctor? If I'm not cured, what will happen to my family? And why has God done this to me? I have never done anything in my life. Okay. So am I equipped to do that? And if I think that I'm not equipped to answer this question, should I not be approaching somebody else who is actually trained to do that? And that's the point where we have to understand that approaching the illness is a multidisciplinary subject. It cannot be done by one person. And that's the reason why palliative care is always delivered by a interdisciplinary or a multidisciplinary team. I hope this concept I have made it clear to you. Now, we have been talking about suffering because palliative care itself gives you an idea that we have to reduce the suffering and thereby increase, improve on the quality of life. So what do we generally understand by suffering? So it's a state of severe distress associated with events that threaten the intactness of the person and occurs when an impending destruction of the person is perceived. It continues until the threat of disintegration has passed or until the integrity of the person can be restored in some or the other manner. So this is self-explanatory, and I am sure I don't need to explain that much. If you have understood what suffering means, you might as well understand how to take care of suffering. So it's the property of the whole person. It cannot be a phenomena that can be reduced to just part of the person. For example, the patient that we just saw, the carcinoma of the cheek. The suffering is not actually just located on the cheek. Just located. It is also located somewhere in his mind. It is also located somewhere to the family that he is there. He has. Through the children that he has, So all this, the whole thing is actually suffering. It cannot be limited to just part. And pain being a common cause of suffering, like many other causes, a severe headache will lead the whole person to actually suffer. I mean, if I have to say that today I have a headache and I just can't talk today. I won't be sitting here and talking to you, taking this particular session. So suffering has to be whole person. So what are the goals of care when we try to understand suffering? It has to be alleviating the suffering. It has to be associated with optimizing the quality of life. Not only the quality of life when the person is living, but till the person dies. And actually thereafter, there's something called the bereavement process, bereavement care, when we talk about a person in palliative care. And then the question of providing the best comfort in death. It is a very challenging, time, both for the patient, the family, and the person who's actually there sitting, waiting for the person to die. It might be the doctor, it might be somebody from the community, coming and giving company to the people. And it might be, someone absolutely unrelated to the person, So providing comfort, how would you do that? If you are trained in providing comfort in death, I think you are a blessed person. And that is the reason why palliative care doctors are first trained in providing comfort in death. We are always taught about end of life care. It is one whole subject in palliative care. Okay. So providing comfort in death gives you another opportunity to understand suffering. You may not have all the answers. Hydrocortisone injection may not relieve the person of the whole of the problems that he is facing at that point of life. Okay. But then, there is something that you have contributed to. So that is extremely important. Persistent and inadequately relieved suffering generally undermines the value of life for the sufferer. So this particular sentence is extremely sensitive, because if I'm suffering from a continuous pain somewhere in my abdomen or at my back, at one point of time, I would actually try and think that, well, I think I have to live with it. So when I am accepting that particular suffering to be a part of my life, I am giving less value to a better life. I am accepting that, okay, fine, I am living with this suffering. मेरे साथ ऐसा ही होना चाहिए था, शायद मैंने पाप किया था. So many things would actually come into my mind. Okay. And that's the reason why I am actually devaluing life. And I would, at one point of time, when it is, it is going above the line, I would actually pray to God that please, either you finish off my suffering or you just finish my life. So the cascade of emotional, problems that starts with a small thing is magnified in something which we cannot even imagine. Okay. The alleviation of suffering is universally acknowledged as a cardinal goal of medical care. I hope you all would actually agree to this particular point, because we are, we are there to give I think, first comfort the patient, and then go on for searching for a cure. And if we do not do that, we do something which is reverse, that would create chaos in the life of the patient as well as the life of the doctor. And then, having said all these things, the ability to recognize suffering is, of course, an acquired skill. You have to practice right from day one to start understanding the person, understanding what he is going through. Do not try to find out an answer to everything that he says. He might actually, I've had patients who actually have come to me and said, doctor, my husband is no longer interested in me because I've had this breast cancer and my breast have to be removed. I have a bad physical image. So he's interested in some other lady. So, those things are also something which are a part of their patient suffering. And I do not have an answer to that. I might maybe, try to give her some relief, saying that there are prostheses, you can do this, you can go to a retreat. But then I cannot actually make her the original person that she was before that cancer. So this is the old concept of providing palliative care. The diagnosis is made. There would be a team of doctors and professionals who would try to give the person a longer life by giving life-prolonging therapies. And then at one point of time, when everything fails and the person actually slips into the last phase of life, they would actually withdraw themselves from that particular person's care. And that goes on to the kitty of a palliative care physician, who would be actually wondering what to give. Is it end of life, or should I start just from basic palliative care? And that palliative care physician may not get enough time to bring about a difference in the patient's life. And at that one point of time, there would be death. And that would be the end of the story. But then the modern concept that was given by Dame Cicely Saunders and many other pioneers in palliative care actually talks about starting palliative care right at the point of diagnosis. Okay. This is mandatory that the life-prolonging therapies, whether it is chemotherapy, radiotherapy, surgery, or any other therapy meant to prolong the life of this person, would take the major chunk of care process. And palliative care may have just a little to offer. Maybe a little bit of counseling, maybe a little bit of talking to the caregivers, what they're facing. Maybe the social worker from the palliative care team would be assigned to find out, what are the government schemes that might help this patient financially. So those are also quite contributory. And as time would take, if there is cure, nothing like this. But if there is no cure and the patient actually slips slowly, there is a downfall in his health, palliative care would actually slowly take the higher side of his life, of the care. And at one point of time, the doctor and the palliative care team knows by means of assessment and the symptomatology that is, expressed by the patient, that the patient is nearing the end of life. And that's where there would be an intensive end of life care, which would be extremely scientific. And that end of life care can be delivered at home, that can be delivered in the hospice, that can also be delivered in a standalone palliative care center. Okay. And of course, death is inevitable. But then the after-death care and, the bereavement care that I had just talked about would be a part of this whole process. And that is where the old concept is actually shoved off by this modern concept. So I was talking about serious health-related suffering. This is a new thing that has actually come up because at one point of time, till I think 2 or 3 years back, we were just talking about holistic palliative care, including end-of-life care, bereavement care. I think we had missed upon a lot of other sufferings that were related to serious health-related conditions. For example, if there is, when there was this tsunami that had, devastated many coastal areas in India and abroad, the after tsunami effects had brought about a lot of health-related sufferings. People were devastated, people had, lost their property, people had lost their lives, people had lost relatives, the contamination of water had brought in a lot of other diseases. Children were orphaned, people had seen a huge load of suffering at that point of time. And if somebody who has some medical knowledge, maybe he is a doctor or a nurse or a health professional, is willing to give some kind of care to that particular chunk of people, what would be the approach? And it was mandated by WHO that any kind of serious health-related suffering, would be considered for palliative care when this suffering is linked to any kind of illness or injury. Okay. So as per definition, health-related suffering is deemed serious when professional intervention is necessary and when it adversely affects the physical, social, spiritual, and or emotional well-being of a person. We all know about the 3 great skills in medicine. It is the diagnosis, the treatment, and prognosis of a disease. But as we can see, over the past 100 years, the prognosis has gradually given way to treatment as the core clinical skill accompanying the diagnosis. So we generally diagnose and then we go straight away for treatment. We do not really think about, what would be the prognosis, what might come up, what might be the natural history, course of the disease. We have, unfortunately, just sidelined prognosis. But prognostication in palliative care is one great skill that you have to acquire. It is a prediction of possible future outcomes of a treatment or a disease course based on medical knowledge and experience. And because of the uncertainty of the future and the complex dynamic system of the human body, prognostication can seem a little mysterious, it can be a little unknowable, and it's all the more powerful also. Through applying scientific methods, medicine has and can make advancement in predicting medical outcomes, despite the formidable task. We are definitely not, astrologers, or we are not of that genre, but because of the skill that we have through medical knowledge, we can actually very, very accurately prognosticate a disease outcome. And that is where, the palliative care people have an advantage, because they would actually take an action only based on the prognostication. If I know that my patient may not live after 6 months, I would design my treatment or the care process for him in that particular direction. If I know that the natural course of a patient with end-stage renal failure would be in this particular direction, I would actually design my care process for him in that particular manner. So prognostication in palliative care is an extremely powerful tool. So why do we prognosticate? Why is it important? Because we want to provide our patients and their families with information. And when I say information, it has to be the right kind of information so that they can set their goals, they can set priorities, they can set the realistic expectations of care to help the patients develop insights into their dying. If a patient is dying and, sometimes he would actually try to talk it out like, why am I living now? What is the purpose of my life? So all these things are insights into why they're dying or why they're living. Of course, it is also important to assist clinicians into their decision-making. As I said, if I know the course of the disease, if I know what is going to happen in the next few weeks or few days, my decision-making for the patient would be in the right direction. And then to compare like patients with regard to outcomes, to provide a common language for healthcare professionals involved in the end-of-life care. So this is an important tool in palliative care. If you can see this particular table, there are 5 Ds of prognostication that has been designed by Fries and Ehrlich. So first D stands for disease progression or recurrence of the disease, which is quite common in cancer. Example being, what is the median survival of a patient with colon cancer who has liver metastasis? So if you know that the person is a patient of colon cancer but has a liver metastasis already, you know what the prognostication is, the prognosis of the person is. Death, for example, what future problems will this patient with advanced oropharyngeal cancer and dysphagia develop if I put a gastrostomy tube? So I know that this patient I might lose this patient if there is if I put a gastrostomy tube. It might not actually solve his problems. It might actually escalate his problems. Disability, will this patient with a cord compression walk again? Drug toxicity, how long will this opioid-induced nausea last? Okay. When I talk about opioid-induced nausea, I'm sure in the consequent classes, you're all going to learn about opioids a lot. If you are able to remember this particular sentence, you will know the importance of this question. And of course, the dollar or cost, will it cost more to manage this patient's pain according to the recommended guidelines? Okay. So this 5 Ds in prognostication is a kind of guideline or kind of acronym that you can use. So many factors influencing the individual prognosis of a patient, but may not. It's all self-explanatory. You can actually go through this later in your leisure. You can just go through this and find out. So when we talk about pain in palliative care, we we think about the concept of total pain. And for us, pain is not only physical. There is a spiritual dimension, there is an emotional dimension, and there is also a social dimension to pain. So if you remember the first, the patient that we had just discussed, when we think about the illness of the patient, not only the disease, but also the illness, it actually gives us a picture of the total pain that the patient is enduring. It might be, the emotional pain, which might be depression, which might be anxiety, which might be frustration, it might be hopelessness, okay? And if there is a spiritual dimension that we need to understand, he might be feeling guilty of something. Maybe I have had so much of tobacco when I was young, and that has caused this cancer. So that's a feeling of guilt. And that might also, lead him to think that God has punished me. All right. Thinking on the social dimension, of course, I'm just use this person now. I am not able to feed my family. My children will suffer. So that's a social. If I have to think about, from the perspective of the family, just take an example where this patient has this foul smelling wound. He's from the lower socioeconomic strata where education is less. The children are not allowed to mingle with the normal ones. The parents of the normal children, the parents of those other children would actually tell them, don't go to that house. That person is cursed. Don't play with their children. So there is a factor of social alienation for that whole family, So this particularly is the concept of total pain and the perspective of looking into the illness of the person and not only the disease. These are some patients that who might have had such kind of a total pain concept. You might actually keep on, you can build up your own story based on every picture that you're seeing. This is a very, this picture actually gives me a lot of strength and, keeps me moving all the time because this is Palliative India's picture. And I had seen this patient along with my mentor in Palliative India when I was doing my training, and this patient actually was standing because of penile cancer and pain throughout his body. He used to stand for hours and hours and hours. He was unable to sit at all. When I talk about this patient, many people do not believe me. It can never happen. They say it can never happen. He has to sit somewhere, But I've seen this patient with my own eyes. He was standing the whole time. It was a severe neuropathic pain due to the penile cancer. You can see the scrotal sac, such big and tense. We were not able to do anything to this patient. That's where, I want to stress upon the fact that we as palliative doctors do not have answers to everything. So before even trying to give a solution to something or the other, we have to accept the fact that we do not have answers to all the questions. Okay. And that would actually make us more strong. That would give us the energy to find out more reasons as to how can we actually help this patient. Okay, this patient passed away after 48 hours of admission, But then this has been a learning point in many of our lives at that particular point of time. This is a 16-year-old boy. Can you see the shape of the lip, what it has turned out to be? So these are ghastly pictures, but they are real pictures. And I'm sure, in your practice, whoever is working with cancer, whoever is working with terminal patients, you might have actually come across your own set of patients like this. These are another group of patients that I can show you of. So basically what I want to say is, it is active medicine. We have to do a scientific evaluation of physical problems like pain, breathlessness, and many other issues that a patient comes up with. It's not like, sitting with the patient and crying and holding hands. It's not like that. You have to study. You have to go into depth of every physical symptom that you see. As doctors, I mean, I have the bug of, getting into the core of what is happening, the kind of medication that I am going to prescribe. How is it going to impact on the patient? What are the adverse effects? What are the side effects? What might be the toxicities, So it is active medicine. We have to study. We have to get to the core. Having said this, physical symptoms are just the tip of the iceberg. And if you take care of the physical symptoms properly, if you take care of the pain properly, the person actually comes out with all other issues that are embedded inside him. He comes out with emotional issues. There would be spiritual issues. There would be so many other issues like issues of sexuality, issues of social distress, broken relationships, separated children, so many other things. So once we take care of the pain, once we take care of the physical suffering, the other sufferings actually comes out. So our professional role in palliative care as doctors is firstly taking direct responsibility for addressing the symptoms. Nobody else, rather than the doctor and the nurse, is going to take this responsibility of addressing the symptoms. Secondly, we have to take a lead role in the area of emotional support. If we do not involve ourselves, emotionally with the patient, if we do not understand suffering of this patient, we will never be able to get ourselves into that other part of the embedded part of the iceberg that I've just shown. And then, of course, we may not be so strong as a social support, but we can always facilitate that. We can get this patient connected to certain people or certain organizations who are able to help. And I'm sure we all have that much of capacity. And then coming to this spiritual support also, I'm not going into detail of spiritual support because you'll have a very different overview when you take the other sessions in this course. So basically, if you're asking me about, well, where do I stand if I have a pool of patients? How do I know that this patient needs palliative care? So there are a lot of tools to find out the need of palliative care in a pool of patients. So if you know, basically, you're approaching a person, approaching a patient, and you have this idea that, yes, this might be the person. So you ask the caregiver of this person, the wife maybe, this surprise question: would you be surprised if your patient or your husband dies within 6 to 12 months? this is extremely a surprise question. The wife is not prepared for this, but you have asked this question. And I am banking on this question. I'll tell you that 99% of caregivers would actually tell you that, yes, I will not be surprised if he dies. Okay. You can add a double surprise question, and that would be, would you be surprised if your patient is still alive? So you can actually, it's a kind of a puzzle. You can make a small, what I generally do in my OPD is make small cards where this question is written in the local language. And if I have to, tell them the prognosis, I would actually slowly push that card to the caregiver and ask them, what do you think about this question? And you will have your answer in that. And that would actually, open the gates of properly communicating, giving them the prognosis, giving them the chance to question you on the condition of the patient. And that solves many problems, many problems. So you'll find this in the SPICT tool, and it's called the SPICT tool, and you'll find this in this particular website, which is from the UK. And they would be, you can also find it in the palliative care screening tool, which is based on 3 basic things. Basically, the basic disease, the comorbidities, and the functional status. So the scoring system is also there. You can actually go, but I basically bank on the surprise question and the double surprise question. So as I've already, we've discussed about this, but then cancer is one big implication. And right now prevalence is, I'm actually giving you this report of 2012 and 14. The other one has not come up as yet. So current cancer prevalence is 2.5 million. New cancer patients registered annually is 0.9. You can see that most of our patients, almost 2/3 of our patients, come in stage 3 and 4, and that actually mandates palliative care in cancer. In the aging population, India itself is aging. And if you want to have a proper aging population, you can actually see the population of Japan. 90% of the population in Japan is above the age of 60 years. And presently we have around 100 million elderly, expected to increase by 324 million by 2050. So, and if we talk about cancer, 60% of our elderly are affected by cancer. So, this is a kind of time bomb that we are sitting on, and a huge amount of people, huge load of patients will be there in all palliative care centers. Palliative care is anyway, increasing. We have to build up capacity, and as today's responsible citizens, responsible doctors, we have to take the ownership of giving out services to our patients. The question of opiophobia, well, I'm not going into details, but you will have a lot of discussion on this when you learn about opioids. Present scenario, we have the National Program for Palliative Care. Those of you who are already with the government setup, you must be knowing about the NPPC program, and created in 2012. it's a small flexi pool kind of a thing, but then at least some part of palliative care is already ingrained in the basic healthcare system. So old act of NDPS has been amended, as I have already told you. Dr. Rajagopal sir has immensely contributed to that. As far as I remember, I think he used to sit in the Supreme Court for hours long just to get this file through. If any of you are, interested, then you may actually opt for MD in palliative medicine in TMH, in All India Institute Medical Sciences of New Delhi, and many other centers have now, private centers have now opened with DMD in palliative medicine also. Pallium India as such is definitely running their own courses, state-of-the-art courses, and I have, and I would continue to tell people the importance of getting a proper basic knowledge of palliative care from institutes like Pallium India, because it's going to open up many receptors in your mind to take the right kind of palliative care training. Okay. There would be many other people who are actually running courses, they say they are, but then there would be only few people, few organizations giving you the right kind of training. So the big question is, do you want to die in this manner, or would you want to die in a manner where you are surrounded by machines, you are surrounded by, you are poked with all kinds of pipes and everything. So if I were to take some inspiration and think, if 15 years back when I was just new to palliative care, I had always, thought about this particular African proverb, which says that if you think you are too small to make a difference, then you have obviously never slept in the same room as a mosquito. So keep on bugging people, keep on giving small tips and points to keep them motivated to be in palliative care. Keep yourself motivated to be in palliative care. It's going to change your life for good, and you are going to bring about a difference in people's life, whoever you touch from now on. So thank you so much for a patient hearing. I think I have taken major amount of time, and maybe we can just talk about the case scenario. Thank you so much for a patient hearing.
Thank you, ma'am. Ma'am, maybe for 5 minutes we can take up questions, and after that I can start with the model case presentation followed by discussion for another 5 minutes. Is it okay, ma'am?
Absolutely. Yeah.
Yeah.
All okay for me. Yeah. Thank you.
We have one question in the chat by Dr. Almas. So she's asking, what is intactness of the person? Also, sometimes suffering may continue until death. Dr. Almas, would you like to unmute and, ask?
Yeah, that would be a good thing, because it's a very, very good question, very pertinent question, actually.
Yes. Hello, ma'am. Thank you so much for the great session. I'll straight away come to the question. So this is regarding the definition of suffering which you gave. And you said that, it affects the intactness of the person, but I'm not quite sure what that is meant. Perhaps it is around, the wholeness of an individual. You mentioned that it's not just a pain, let's say in a finger, but suffering as a whole. But intactness, I'm not sure how I'm not sure what exactly you mean when you say that the person is intact. Also, you said that it will continue till that situation continues or if it is resolved, but there could be times when we are unable to do anything and the patient then passes. Uh, yeah, I just wanted to just get
Yeah,
some clarity. Thank
yeah. That's a great question. So I'll just try to explain it in a different manner. What difference do you see in yourself and a person who's born blind? What is the difference that you see?
So to me, the entire perception, I think, would be different for the two of us. Uh, a lot
So
of
would you, so would you think that your perception uh, is better than what the blind person perceives?
I wouldn't say it's better, but it would definitely be different. A person who is born blind would adapt very differently to a lot of things. Perhaps hearing would be sharper. I mean, I may be giving a very wrong answer, ma'am. I'm sorry, but
No,
I think
it's
it will
not
be
a wrong
different.
answer. So you are definitely trying your best to explain. So the point is that, a person who's never seen light, for him, whatever he is feeling, he is hearing, he is talking, he is interacting in his own manner with his own strengths. That is his intactness,
Yeah, okay.
right? And if by chance a person who's not born blind becomes blind for some reason,
Something is
his
subtracted.
intactness would be disrupted. Do you understand?
Yes,
So the intactness of a person is that it is
everything
individualized.
everything
It is
that the person is capable of.
absolutely. If you take away something from a person which he already possesses,
Yes,
we are
understood.
disrupting his intactness. Am I able to answer a question? Am I able to give you the overview of what intactness means now?
I could get it now. Yes.
Yes. So the point is, as I have, stressed in throughout the session, that palliative care has to be individualized. Okay, it has to be tailor-made. It is different for different individuals. So that is where we have to understand what might be the intactness of a person when we see. So this person gives you his overview of his quality of life. This person gives you the disturbing elements that are there in his life. And he tells you, I want to get rid of them. You need to find out how to help him.
Sure.
You have to see, there are certain, SOPs or, guidelines to take care of pain, to take care of, breathlessness and many other things, even in communication also. But then you have to individualize it. You have to find out is, for example, if I have to say from the doctor's perspective, taking care of pain, you have to evaluate pain for one person. If you find it of an intensity of say 8 on 10, and the other person says, no, for me it's 5 on 10. You just cannot give the same medication to both of them. You have to individualize. Okay, so individualizing is the key in, defining the intactness of a person.
Sure, ma'am. Thank you.
I am really not, I don't know whether I have satisfied you.
You
but
did,
then,
ma'am. You did.
yeah.
Thank you so much.
Okay, yeah, thank you. Somebody else had a question, I think.
Yes, ma'am.
Yeah, Dr. Dilip raised his hand.
Yeah, ma'am. Dr. Dilip Bora. So, wanted to
Yeah.
check the one case which you showed about that small boy with penile cancer. and
Yeah.
you said he could not, he has to stand to reduce his pain.
Yes.
So whether that person was not able to sleep also on the back or something?
Absolutely right. He was not able to sleep. You will learn about neuropathic pain more when you do your pain classes. But this person had penile cancer, and he was in his terminal stage. All his nodes, starting from the iliac to the retroperitoneal nodes, everything was involved. As you would have seen in the picture, he had a lot of tense scrotal edema. He had bilateral lower limbs edema, and there was a phenomenon that's called allodynia, and he was unable to wear clothes also. It was the extreme level of suffering that I have seen in this particular patient. Actually, I've not come across any such patient in my life.
Okay, ma'am. Thank you.
Okay.
Thank you, ma'am, for your answering all these questions patiently. As of now, I think we'll move with the case presentation and then we'll take
Yes,
Dr.
please.
Sonia's question. There's one more question in the chat
Okay.
box.
Yeah, sure.
Can you please share the screen? Yeah. So this is a model case presentation for all of you to have an idea about how this generally goes about. So next slide. So this is a patient who is 39 years old male with traumatic quadriparesis with stage 3 pressure sore on the sacral region and left gluteal region. Next slide. So the presenting complaints were large pressure sore over the sacral region and left gluteal region for 3 weeks and pain over the left hip region and pain over the pressure sore for about 2 weeks. Next slide. So he had a history of fall while carrying heavy weights, which was followed by neck pain and weakness of both lower limbs. He was taken to Medical College Hospital at Trivandrum and was diagnosed with traumatic quadriparesis in August 2023. He got admitted and treated from there and was discharged after 1 month. After 6 months, he developed a bed sore over the sacral and left gluteal region, which is of stage 3. The history of pain over the left hip and wound site was there for about 2 weeks. So here I have written about the pain assessment. So the pain over the left hip region onset was 2 weeks. The provoking factor was minimal movement. Palliating factor was rest and analgesics. The quality was continuous aching type. There was no radiation. The severity was moderate. The temporal factors were nil. Next slide. The pain at the site of the pressure sore onset was for about 2 weeks, provoking factor movement, palliating factors, analgesics, quality, continuous throbbing type of pain. Due to this, sometimes they keep the wound open. The radiation was nil, severity was moderate, the temporal factors were not there, and the pain score was 4 by 10. The sleep was disturbed due to pain. His oral intake was good. The bowel and bladder habits were normal. Next slide. On examination, patient is conscious and oriented. The vitals were normal. The systems were normal. On local examination, the sacral region, the pressure sore was of size 7 into 6 centimeter, irregular in shape, which is of stage 3. There was foul smell as well as slough. In the left gluteal region, the size was 6 into 8 centimeter. It was irregular in shape, stage 3, slough present along with foul smell. Next slide. So these were some of the relevant investigations that were done. His pain was controlled with analgesics and wound care was given twice daily with metronidazole irrigation as there was foul smell, and skin care was also given. Physiotherapy was also started. The treatment given was capsule tramadol 50 milligrams 3 times daily along with SOS doses, tablet paracetamol 650 milligrams every 6 hourly and SOS, tab bisacodyl 5 milligrams 2 tablets at the night, syrup lactulose 15 ml HS as SOS, tab metoclopramide 10 milligrams 1 SOS. Airbed was advised, position change was advised, wound dressing twice daily, and cleaning and dressing the wound with Debrides ointment over the slough region was advised. For foul smell, metronidazole irrigation was advised, it was done, and the wound was kept closed. White petroleum jelly was applied for local application over the skin, and regular physiotherapy was continued. Next slide. So here, while moving into the psychosocial aspects, he is a 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling who is married and living separately and not caring and helping them. He was a manual laborer and was a breadwinner of his family. Now his mother has taken up work as a manual laborer and she is taking care of him. Now the main source of income is from mother's daily wages, her pension, and some of his friends are also helping him. And they have taken around 1.5 lakh rupees from private finance bank for the treatment purpose. He's a devout Christian now. Because of this condition, he is unable to go to the church, and this makes him really sad. He says to his mother, like, I don't think I can walk, so please don't spend money over my treatment. Next slide. So the main concerns noted were pain, pressure sore, as well as financial problems. Along with that, the emotional aspects to it. Next slide. So the summary goes this way: a 39-year-old male with traumatic quadriparesis and pressure sore over the sacral and left gluteal region with pain over the left hip region. So the discussion points are: do we need to provide palliative care for this patient? What are the problems faced by this patient and what all can be done for this patient as well as his mother? So this is how generally a model case presentation, this is a model case presentation that I have done. So we want you all to come up with cases. As of now, we have received around 15 case presentations from the participants. I really thank you all for that. And especially with respect to the discussion point, this is some model questions that we have put here, but we want you to add discussion points relevant to the topic for that day. For example, if it is on pain, if it is on difficult pain, if it is on wound management, we want you to add and modify these discussion points appropriately so that you bring very important points for discussion in the whole session. So that is what we expect from you. And also we want you all to send the cases as soon as possible so that we can do the initial vetting. We will have an initial review of it and we will add our comments on the same and we send it back to you via our virtual coordinator, who's Gayatri. You can always reach out to her if you have any doubts regarding case presentations. And once she sends it back, we want you to correct it because it will be very few corrections that we would have mentioned. We want you to correct it and then send it back within 24 hours and so that we can keep it ready. Out of all the cases that we receive, we will be selecting one best case for presentation on that particular day. But please note that all your case presentations are taken for evaluation and that is one of the mandatory eligibility criteria to get your certification. So that is the reason why I brought in a model case presentation so that you have an overall idea of how this is done. So usually once the faculty presentation is over, we have 5 minutes of discussion and then we give 5 minutes for the participant to present the case. So be very familiar with the case. And once you finish your presentation, we can start with the discussion points relevant to the case scenario as well as to the session. So with that, I conclude and I think we can move on with the questions. If you have any doubts, please drop it in the chat box. I'm okay to take that. Meanwhile, Sanghamitra ma'am, we have one question from Dr. Sonia. So it is about the surprise question. So she's asking, is it a positive or negative approach or neutral approach? For example, from our end, we are trying to prognosticate, but we may receive some flake or the family may perceive us as someone crushing hope.
Yes. Okay. Dr. Sonia, so what makes you ask this question to me? Dr. Sonia, can you hear me? She's there.
Dr. Sonia, can you please unmute and answer? She is available, ma'am.
She's there?
Yeah.
Okay, so I just wanted to know what what has made you question this thing? Like, what is the reason that you've asked this question to me? Because that will give me a clue to answer this question actually.
Well, I think if ma'am, Dr. Sonia is unavailable, we can take Dr. Dilip Pawar because He has been raising his hand for long.
Acha, yeah, okay. I
Yeah.
think Dr. Shamim has also raised her hands.
Yeah.
Yeah, Dr. Shamim, yeah.
Ma'am, I just wanted to add to the same question actually, Dr. Sonia's question, because this is something I also felt. It's, while asking the surprise question, of course, I'm not practicing in that setup, so probably I feel this more, but it is just, a slight awkwardness while asking this question. Since it is a surprise question, it also takes us by, if someone asks us such a question about a family member, because it's death, and it, as you also mentioned, it is a taboo topic. uh, People might snap back at us, calling us inconsiderate, as she has mentioned that people may feel we are crushing their hope, we are compelling them to think about the death of this person. I also feel this itself is an answer that they are surprised and they were not prepared for the person's death.
So what do you think would be the right approach to ask this question? See, this is a question that you have to ask. This is a tool which is going to help you prognosticate. So how do you think you should be placing this question? Where, when, how are the things like? So you give me a clue so that I can guide you. Sorry for taking this time. But this is very important because I really don't want anybody to take a negative thing from here. So that's the reason why I'm asking you. When do you think you should be asking this question? Number one, where do you think you should be asking this question? And who do you think you should be asking this question?
May I answer, ma'am? If Dr.
Yeah, of course.
Yeah.
Please do. Please.
Ma'am, I think, so whom should be the primary caregiver, who is the primary attender, of course.
Right.
And when, again, please correct me, I feel when we ourselves have an understanding of the prognosis of the patient and we feel it is not a very positive prognosis, perhaps then we can ask this question.
Yeah.
And instead, again, I'm sorry, ma'am, but since you asked,
please don't be sorry.
perhaps not asking about debt, but something more practical in terms of, let's say, finances.
No. You cannot
Oh,
change.
we cannot change. Okay,
No.
then,
Because it's a tool. It's a validated tool,
Okay,
So
okay.
you have to ask that question only.
Okay, then these are the only two things. When we ourselves know that it's going to be a bad prognosis, as otherwise, I'm not sure, ma'am. Sorry.
So you've given me two clues. Number one, we know the prognosis already. Don't you think so?
Yes, ma'am. Only when we know we.
So we know that the prognosis is bad, right?
Yes.
But we have to put this in a tool so that we get an answer. And that tool says that we have to put this question in a surprise format to the caregiver or to the patient. Basically, it is to the caregiver. Because the caregiver who's there has been taking care of this patient since a long time. And when the caregiver is taking care of this, her or his patient since, maybe 2 or 3 years, she or he has actually traversed the road to decline since a long time, almost had seen the milestones.
Yeah.
Now, in palliative care, generally when we prognosticate by months, years, weeks, days, hours, right? That is the scientific way. But we have to make this thing, the patient, the caregiver understand this process. Okay? When you put this question, the place where you do it is in a closed setup where, the caregiver is with you, talking to you regarding the diagnosis of the patient, regarding what will happen to the patient in the next few days. Okay. This is part of the communication skills also. when you start talking, you actually give clues, hints to the caregiver. All right. And when she is conversing with you, okay, let me give you an example. So this patient, this caregiver is there, and she actually says that, doctor, I would like to have some time with you. I need to talk to you about the issues that my patient is having. So definitely, you should expect that she will say, I'm not seeing my patient getting better at all. I understand you have been trying a lot. You have been giving a lot of medications. The whole team is actually taking care of the patient, but I really don't see him getting better. What do you think is happening to him? Then you put forward your observation in that. Okay, that's true. We have tried some antibiotics. We have tried pain medications. The pain is actually coming back. We are not able to. So you are already trying to give that person some cues that perhaps the patient is going down. Now, in this particular process of conversation, all of a sudden, you have to come up with this question. Okay. Where do you think the patient is going? If you can understand Hindi, आपको लगता है कि वो 6 महीना निकाल लेंगे इस तरह से? Okay. It's not like, you have to put it in the same language that it is. You can actually put it in your own thing. Do not change the question, crux of the question. क्या आपको लगता है कि 6 महीना निकाल लेंगे इस तरह से? And you'll be surprised to know, in my experience, at least 90% of caregivers are actually doing, नहीं, मुझे तो नहीं लगता है. And that actually, they have answered their own question. That makes things easier for you. And please take it from me today that this really doesn't create any kind of negativity. That gives them a clarity of what they have to do in the future. This you are going to learn a lot in detail in your communication skills classes. Where to approach, how to approach, whom to talk to, what is the advantage of silence while you converse with the patient? What is the advantage of giving time to the caregiver when the caregiver is on the verge of crying? Okay, how to handle that particular anxiety, that particular emotional situation. So these are certain skills that you are going to learn in your, practice itself. And you will have your own guidelines set by yourself. So if you are really interested in palliative care, you will have your own set of guidelines. Nobody will have to tell you that, nahi, aapko yahi follow karna hai, wahi karna hai. Aisa bilkul nahi hai. So you'll actually come out with that. So this surprise question shall remain surprise question. And I generally use it when I know that the caregiver has something in his mind which he wants to talk to me. And when I get a window into their mind, it becomes really very easy for me to actually give them the right kind of direction. I may not be able to give them the right kind of treatment per se, कि भाई chemotherapy और ले ले अच्छा हो जाएगा, but I can actually tell them that, you should not be taking any more radiations, or you should not be going for any more chemotherapy. So that is where this question has helped me a lot. So it's my personal take. You can practice it, see how it goes. There are different tools also, many other tools. If you search the literature, you'll find a lot of other tools. But this surprise question tool is a really good thing. Like it opens the floodgates of the emotions of the caregiver.
I have one doubt.
And Yes, yes, please. Sir.
Ma'am, you told me that we should tell the attenders regarding the fact that there is no use of giving further treatment like that.
Yeah.
Actually, I'm just sharing my thought or my query that I'm an anesthetist working in a private hospital. I'm
Okay.
working in a district which is mostly tribal people dominated actually.
Okay.
Thing is that I have seen that two types of attenders are there. Basically, one who will be ready to give every treatment possible till the final stage, and one who is not ready to spend money, or like neglected patients will be there. So much of patients I have come across, and the thing is that we will need a thorough evaluation of the opinions of the bystanders before giving them this option. And another thing is that one more query I am having, madam. The thing is that as I am being a palliative care physician who intends to work in palliative medicine, uh, what if the treating onco surgeon or oncologist has given a different option to them to either continue the treatment? Will it create a doubt? It will create a doubt in the mind of attenders because one doctor is saying that treatment needs to be continued, other is saying that there is no need of treatment. How to handle these situations, madam?
Yes. So you are basically talking about collusion. In communication skills, we generally tag this kind of situations as collusion. You learn more about this, how to handle, how to manage collusion in your communication skills classes. But to give you a hint on what to do in such situations is that you have to first talk to your team, okay? And your team would be the oncologist, your team would be the palliative physician, you being an anesthetist already, if there are nurses. So as I said already, palliative care is a multidisciplinary approach. So you have to take consensus of the whole situation. You cannot just go and talk to your patient like that. That is one thing that we have to take the consensus that, if the oncologist is still adamant on saying that, nay, I will try this, I cannot just, let the patient go, then you really don't have any option. You just can't say, you cannot actually challenge his knowledge, right? But then at one point of time, when the oncologist also, because there is a resilience in everybody, isn't it? He will also actually give way. He will also actually tell you, okay, yaar, bahut ho gaya. I cannot actually, keep on treating the patient. I think let the patient go away in peace. You have the plate in your hand at that point of time, and then perhaps you can place your cards. So you have not actually annoyed your teammates. You have taken their consensus, and you have also tried to place this amicably to the patient and the patient parties. That is one. Second scenario, where you said there would be two set of caregivers, one who is trying to give everything to the patient, another one who's, who might not have the resources to fulfill. So those people who do not really have the resources to fulfill, they will find you as God, okay? They will actually give importance to the smallest of advice that you give them, because they understand that they do not have any choice, and the doctor or you are trying to give them the best that is possible. Having said this, you have to show this through your behavior, through your communication, through managing the very difficult physical problems that is there. Okay. Once the caregiver actually sees a difference in, how the pain has been managed, because pain is universal. I mean, you can definitely take care of the pain, right? You can bring it from 9 on 10 to 2 on 10. Absolutely. So that difference is actually going to change their mind or perception about you. Okay. That is one. The other person who is a little, I should say, a little bit of the troublemaker one who wants to give everything, just let him cool down all by himself. Sometimes we have to go 2 steps beyond, backwards in order to take a leap. So just step back and tell him, okay, fine. He's your patient. I want him to be better. Your intention is always the best to make him better. So please do that. But then my medical knowledge says that if you keep on treating him like this, the adverse effects or the side effects of such medications will one day, make him more weak. He will not only get worse, but he might also die. That is my experience with other patients, and that is the reason why I'm giving you this advice. Okay. And at one point of time, he will also see the difference in physical status, because he will, and then actually you can actually tell him upfront, and I have done that quite a lot of times, that your intention unconsciously or subconsciously is that you are getting satisfaction out of the fact that you are treating your patient. But the fact is that your patient is not getting better.
Yeah.
Okay. So sometimes we have to be a little blunt also, because, he's trying his best to give the best to his patient. We are also trying our best to give the best to our patient. Okay. But somewhere there will be a friction, and we are the intelligent ones and the educated ones to manage that and take control. So that's how I have been doing. So maybe you can just try and follow.
Thank you.
Thank you so much, Sanghamitra ma'am, for giving such wonderful explanations for each and every question. Dr. Ahmed, so you were talking about communication. So we have a session upcoming on June 26, where it is fully about communicating bad news and pollution. So you'll get an entire picture of how that is to be done and all of it. But anyway, I think ma'am had justified by giving a very brief explanation about all of this. Thank you so much, ma'am. And I think because of the time constraints and all of it, I think we need to close with this session for today. I thank each and every participant who has joined today, being very interactive right from the beginning and posting your comments in the chat box. There were a few comments regarding case discussion and all of it. So Gayatri will be there to help you all on all of that. You can message her on WhatsApp and she will be able to help you. And so with that, I close, and thank you, Sanghamitra ma'am. I hand over the session to Gayatri.
Thank you, Sanghamitra ma'am and Dr. Hashmat for the wonderful session. As always, the session is enriched with much of knowledge. I know everybody should aware and well knowledge about all the topics learned. And thank you all for participating in the session. Let's see again with another session. Thank you all.